Hi there, and welcome. My name is Jeff Bell, and on behalf of McLean Hospital, I'd like to thank you for joining us for yet another episode of our educational webinar series. Today, we focus on OCD and anxiety disorders, and specifically what sets them apart. OCD can manifest in a wide variety of ways, from checking and counting to ruminating and hand washing. And while it's often thought of as an anxiety disorder, diagnostically speaking, it's something distinct. Meantime, there are all kinds of diagnosable anxiety disorders, each with its own distinctions. So, our goal today is to explore how clinicians go about diagnosing these conditions so that they can treat them effectively. And to that end, I want to welcome Dr. Jesse Crosby, a clinical associate at McLean Hospital. He has specialized clinical and research experience with perfectionism, OCD and related disorders, anxiety, and behavioral addictions. Jesse, thanks so much for making some time for us.
Good to be with you.
Well, we're thrilled to have you with us. I want to mention I am one of the millions of people living with OCD and someone who has benefited greatly from effective treatment. I also know how critical it is to get a correct diagnosis, and that's our topic today, of course. So to start us off, can you share a bit about anxiety in general? It's something that everyone deals with to some degree, is it not?
I think that's important to be clear about, that anxiety is a natural or basic emotion that each person, I think, is built to experience. It's probably a useful emotion in a lot of cases, in that it helps us avoid dangerous situations or respond to threats in our lives. Where we look at that as a disorder is when it is excessive or exceeds what we might experience as normal anxiety, whether that's just through the intensity of the situation or the repetitiveness of the situation. Fight or flight system, body response to anxiety. If you have some kind of threat, pretty normal. Good responses. We wouldn't want to turn off your anxiety system. But just like a lot of stuff in the body, it can be on a spectrum, and sometimes it can be too much and start to cause really big discomfort and impairment for people.
Are there any particular thresholds that you're watching for that when they're crossed, you're looking at more of a clinical diagnosis?
Yeah, I think the two big ones that we always watch for are, first, what we typically refer to as distress. Like, how intense is the distress? And is the distress so intense that it's causing someone discomfort for much or most of the day, more days than not? And that distress that deserves some relief from that. If it's typical anxiety from a usual stressor, say if someone has a close call while they're walking across the street, we'd expect a fight or flight response to that. And then as some time passes, for them to settle back in and be able to go on with their day. But if their anxiety is there through much of the day, most of the day, or more days than not, then that distress deserves some attention. The other thing that we watch for is how impairing it is, or how much it gets in the way of their ability to live their life. And so if their anxiety is so intense, or some of their responses to it are causing such disruption that they can't function well at school, they can't function well at work, they're not showing up in their relationships, or even if their self-care is impaired, then that's when we look for this as a possible disorder, because something has become disordered or disrupted in their life. And it's a good sign to consider talking with a doctor or professional to see if there's something they can do about it.
And we're going to talk much more about the diagnostic process for anxiety disorders and for OCD. That's sort of the focus of our chat today. But I think we need you to paint the picture for us, give us the landscape of anxiety disorders. There are many. Can you walk us through some of the more common ones?
Sure thing. I think they all have very similar theme to them and similar presentation. What often distinguishes them is what the individual is afraid of. And so you could distinguish between them by what their fears relate to. So the typical group of anxiety disorders that we refer to are things like generalized anxiety disorder, which, as you might imagine from the title of that one, there's more of just a general fear where people find anxiety about a lot of things in their life, work situations, family situations, etc. Panic disorder, which is where an individual experiences panic attacks and then develops essentially anxiety about having panic attacks, and a lot of anxiety about, what if I have a panic attack while I'm at work, or while I'm on the subway, or while I'm in a meeting, or while I'm on an airplane. But the fear there is of having panic attacks. Social anxiety disorder, where there's anxiety about being in social situations and possible problems that may occur there. You can get even more specific where you have what are called the phobias or the specific phobias. And this is where people develop marked and really acute fears around specific things, such as blood or needles or spiders or closed spaces. Separation anxiety disorder has been prominent enough that it has its own category. And this is where especially you'll see people in childhood or adolescence where there's a marked anxiety for being separated from parents. Beyond what you would normally assume for where they are developmentally in life. And then you also have OCD and the related disorders, and then the trauma and trauma-related disorders. Typically, these are all thought of as being inside of that anxiety spectrum. With OCD and with the trauma disorders, because they have so much more detail to them, sometimes and more variance, there's been somewhat of a separation to talk about anxiety disorders, and then OCD and related disorders, and then trauma and trauma-related disorders. If you look at the diagnostic manual, you'll see those 3 chapters, one right after the other, purposefully to recognize that there's a lot of similarity and overlap, but just for clarity to be able to distinguish between them, they separate them out like that. So there's no indicator that OCD is not an anxiety disorder. It's just how we talk about it when we're trying to make sense of all of that.
So by way of perspective, what do we know about the prevalence of these disorders? Any kind of ballpark figures you can put out there for us?
It can really vary, but anxiety disorders in general tend to be the most prevalent of mental health issues along with depression. It can be anywhere from like 3 to 5% for OCD, anywhere up to like at some point in someone's life, up to 20% of people will experience things of like generalized anxiety disorder. The prevalence is pretty high, and it is something that is, I think, deserving of some attention, and it can be hard to know sometimes whether or not people should seek treatment for it, because there's often a commonly held belief that like anxiety is a natural part of life. We experience stress, we get nervous about things, but as we talked about, there's that spectrum there, and sometimes it reaches a point where it's high enough that you should seek treatment for it. So even though it looks like it's very common and a lot of people deal with stuff, sometimes it hits the point where it really deserves some specialized attention.
What do we know about the causes of anxiety disorders?
So there are various theories about it. Typically, it looks like it's a combination of factors. For many people, just biologically, there's a predisposition for that. One theory in particular would suggest from some data that people who have anxiety disorders have a fight or flight system in their autonomic nervous system that is more easily triggered, may get triggered and set to a higher level than you would normally expect, and maybe takes longer to come back down. And so as they're, say, experiencing normal day-to-day stressors, what someone else may experience is like, like a 2 out of 10 on a distress scale, they may experience is like an 8 out of 10. And then it stays at an 8 for several hours. And so it kind of creates this experience where regularly they feel like they're constantly at threat. Sometimes experiences people have growing up in life can also contribute to the formation of anxiety disorders in terms of experiences with family, traumatic experiences, maybe anxiety disorders in parents, and then the meticulousness of the parents is shaping how that kid learns to look at the world. So we can see a socialization aspect to that. Traumatic experiences can cause it. And so usually when working with an individual and trying to figure it out, we try to paint a picture of where different aspects of their life could have all come together to influence that.
Let's zero in on OCD for a moment. And again, just to be clear in our vernacular here, the DSM has now called this something separate from an anxiety disorder. So we're going to refer to OCD and anxiety disorders.
Okay.
What exactly is OCD?
Obsessive compulsive disorder, characterized by 2 primary things: the presence of obsessions and the presence of compulsions. So obsessions are persistent, recurring fears and thoughts related to some kind of discomfort, concern, threat of some kind of fear that this person is facing. And that can be really specific, like fear of contracting a specific disease. It can be more general, like a lot of worry about causing harm to someone else, or a lot of worry about um, just general health issues. It can be a preoccupation with certain things, so needing things to be ordered and organized, looking for just a feeling or a sensation in order to feel comfortable. So there's an obsessional focus on that. It tends to be preoccupied and repetitive and persistent. So a way to think about that is that something that someone thinks about for most of the day, more days than not. Those obsessions are often joined by compulsions, which is our behavioral activities that people will do, often as a response to the obsession, and usually to neutralize or to control the obsession. So, for example, if someone has a fear of contracting a disease or an illness, and as part of that fear, they worry about not only contracting the disease, but spreading it to someone that they might love or care about, and then causing harm to someone else, then that person might be obsessively focused or consistently thinking about where they might be exposed to illness. So they would be very thoughtful about how they act in public situations, what they touch, what they're around. And then the compulsions often involve a lot of care taken to avoid or neutralize any of those concerns. And so that may be things like avoidance of situations that they might normally like to be around, say public situations, crowds, etc. Avoidance of using public restrooms for the fear of the germs they might contract there, avoidance of restaurants. It also can involve behaviors to neutralize anything. So if they do have to use the bathroom, there may be prolonged hand washing behaviors or prolonged decontamination behavior, use of decontaminating wipes and things like that to be able to control or neutralize the concern about those germs. A quick note about compulsions is they can be external behaviors that we can see, but sometimes they can also be things that we do in our minds. That sometimes we refer to it as compulsive rumination. So let's say that someone has a fear about how they present socially. And we've seen a lot of this recently when there's been a lot of focus in our society on just wanting to be really careful about offending others, especially with marginalized communities. And so we'll see people have developed this obsessive fear that they may say something that could offend someone else. So they could have a conversation with someone, say at work, and then they might consistently and repetitively review what was said in their mind or ruminate about it, sometimes for hours or minutes, and sit there and check over what was said, think about it. And so even though it's something that's happening in the head, we think of it as like a behavioral rumination where they are purposefully and deliberately thinking through something over and over and over to make sure they said things the right way or where they might have caused some offense.
You see, one of the fascinating things to me about OCD is it would seem on the surface that these different subtypes of OCD are very different things. In other words, somebody might have a challenge with needing to count as a compulsion. Somebody else might need to scrub their hands for fear of contamination. Can you speak a little bit to the fact that content really is not the issue here? It's the cycle itself?
Yeah, the word we use a lot is function. So that while it may have a different behavioral manifestation, it's serving the same function. And so in this case, it's that there's a fear that is experienced as intense and distressing, so much so that there's obsessive focus on that, and they feel compelled to do something to neutralize or eliminate or manage that fear. And that can be anything from fear of germs to fear of causing harm to just extreme discomfort that they feel when something feels out of order and having to compulsively do something to manage that fear. And so that's the function that we look at. We can see a wide variety of how that presents. And sometimes it's more obvious because they're more traditionally known. So it's very common to associate OCD with someone who's focused on germs or diseases or order or an organization. But it can show up around all sorts of little subvariants to it in terms of what someone becomes obsessively afraid of and how they compulsively look for that. If someone's wondering whether or not this may be an issue for them, if it doesn't seem to be a traditional OCD subtype, That doesn't necessarily mean it couldn't have that same kind of function for them. So it's worth a conversation with a doctor or therapist and say, I'm noticing this, I'm worried about this. Is this something that we could look at from an OCD perspective?
I'd be remiss not to ask you about the misuse of the term itself these days. I mean, we often hear somebody describe their boyfriend as OCD because he likes to keep his car clean.
Yeah.
OCD is not an adjective, and I'd like for you to address that as well. And what is the distinction between personality quirks, if you will, or anal retentiveness, and this clinical disorder that we know as OCD?
Sure. So just like any aspect of our lives, people have various preferences for how they like things. Some people like things to be cleaner. Some people care a little bit less about that. Some people like to be meticulous and organized and keep lists and to-do lists, and some people a little bit more haphazard about how they may do things. A lot of that is preference or style, and especially if it's functioning for them and they're working well and doesn't cause any issues for them, we just look at that as something that somebody does as part of just their natural way that they operate in life. In casual language usage, OCD has been kind of used to sometimes describe someone who's clean or a neat freak or just needs things to be organized or whatever. And it does a couple things. First, it takes something that's just a normal preference for somebody and labels it as a disorder. And second, for those who really experience the disorder, it minimalizes or trivializes their experience because what they go through is so much more than a preference. A key component of OCD is that these obsessions are experienced often as unwanted intrusions. These are not things that they truly would want, but the fear is just so intense that they feel compelled. It's in the name, compulsed, or this compulsion to do something that they don't want to do, and they don't like that disruption. And I think having spoken with many who go through that, it is really hard for them to see that used in a trivial way because it tends to be somewhat dismissive as something, well, if that's just your preference, then don't worry about being clean. Well, that's not necessarily what's going on here. They don't choose what kind of fear shows up, and they certainly don't choose how intense that fear feels. It can be helpful to think of like two people who experience the same thing. One person could experience that as like a 9 out of 10 on their distress scale. The other person could experience as a 2 out of 10. That's going to change how they respond to that. And that's not always fair how that is distributed in terms of who experiences what.
Great explanation. Let's talk a little bit about some of the OCD-related disorders as they're known. Things like hoarding disorder, trichotillomania, body dysmorphic disorder, skin picking. What should we know about those challenges?
Similar to the anxiety disorders where we'll separate them based on like the topic or the focus of where the fear is pointed, we'll see that with OCD. So there are some challenges that people experience that have thematically similar experience with obsessions and compulsive behavior. They are sometimes distinct enough from traditional OCD that they deserve some separate recognition. They also have some smaller variants in terms of like how they show up or the way that they function for someone that they deserve some separate attention. So you'll see that with hoarding disorder, where there's obsessive focus and a lot of compulsive saving, keeping or not throwing away items, sometimes to the point that it reaches a health hazard in terms of the amount of stuff that someone is holding onto in their home or in their space. As we've seen technology change over the years, we've also seen a lot of digital hoarding, and this may be where people are keeping digital photos, digital files to the point that their devices and computers are just completely overloaded with stuff that it creates a serious problem in terms of the amount of time they spend collecting and hoarding that. We see it in trichotillomania and skin picking. Trichotillomania is essentially this feeling this obsession or urge to pull hairs out of the body, and then feeling that compulsion to do so, often from the head, sometimes from other parts of the body. And it has kind of an OCD-like feel to it, but it's different enough that it has its own category. In the past, we've referred to it as an impulse control issue, where someone has the impulse to do something such as biting a nail, pulling a hair out, or picking at your skin, and has trouble controlling that impulse. The challenge there can be both the distress that that causes, but also the impact on their physical appearance and some of the discomfort that that can cause. Body dysmorphic disorder is another related disorder to OCD where there's obsessive focus and preoccupation with a particular part of one's body and how it may appear. That can be like the shape of a face, of a body part, muscle structure, amount of muscle, etc. And that they can be obsessively focused on that and feel compelled to do more ritualistic or compulsive things, sometimes more extreme things, to manage that to the point that it causes them a lot of distress or disruption to their life.
Let me throw one more term at you before we move on. PANDAS. What should we know about that? What is that getting at, that term itself?
So PANDAS refers to a form of OCD that we've seen shown up in children and adolescents, sometimes after the onset of some kind of infection. And the theory is that there's potentially some kind of shift in brain biology that triggers some OCD kind of response. And so what will characterize it, if you've got a child or an adolescent who seems to be developing normally, functioning well, and if there's a pretty sudden shift into some obsessive compulsive type behaviors, that can be a good indicator to maybe check out some PANDAS with an OCD specialist. It's not the only time that OCD shows up like this. We often will see OCD symptoms show up as a response to other general medical conditions or medication side effects and so forth. And so anytime some kind of brain biology shifts a little bit, we will sometimes see OCD symptoms emerge from that. But PANDAS has received some attention recently, I think for good reason, to just help parents and unknowing pediatricians understand why did we see this sudden emergence of OCD, and kind of help to kind of look for that with that, so you know what's going on.
One of our goals for this webinar series is to weave in questions from our audience, and we are getting a lot of questions for you, Jesse. We're going to get to those. But first, I'd like to ask you to sort of walk us through the basics in terms of treatment for anxiety and OCD. And I realize that in and of itself is a very long, complicated explanation, but give us sort of the highlights in terms of how these conditions are treated.
Okay. So, in the same way that we talk about the cause of the experience being both biological and from a person's experience, we look at the treatment from the same perspective. There are biological things we can do with medication interventions, and there's also behavioral and social things we can do to help someone manage these behaviors and help them think differently. A really common approach to this that has really solid evidence base is cognitive behavior therapy. Cognitive behavior therapy refers to focusing on both the thoughts or the cognitions related to the anxiety, as well as the behaviors associated with that. With OCD in particular, that there's a part of cognitive behavior therapy we refer to as exposure and response prevention, or it's sometimes called exposure and ritual prevention. ERP is the initials, you'll hear it as. And specifically for OCD, this has proven to be a pretty successful treatment. But it's a hard treatment, and it involves having someone exposed to triggers that would bring up or raise the fear that they are obsessed about, and then to prevent them doing the compulsive response. So an example might be someone who's afraid of exposure to germs, would perhaps like walk into a public restroom, oftentimes with a therapist to coach them right there by their side to help them, have them touch some of the sinks in that public restroom, and basically expose themselves to the fear of contamination by these germs in a public place. And then they're encouraged, not physically prevented, but encouraged to prevent any kind of compulsive behavior. And so they'd be challenged to go without washing their hands as a way to neutralize that fear. And the key ingredient with exposure is both the exposure and the response prevention, but also one more part of that is the repetition of that. The theory is that as we do that repetitively, our fear response habituates. In the same way that if someone was nervous about public speaking, but was in a job where they were doing public speaking almost on a daily basis, they develop some increased comfort with that, increased confidence with that. Same with someone who has fear of flying. If they were flying more often, there's something that habituates or changes with that. So what we're trying to do with exposure and response prevention is to foster that habituation process. We don't completely understand how all that habituation occurs, and there are various theories about what happens there in terms of how we start to think differently about the fears and how our physiological response changes over time. But what we do know is that when people go through those procedures repetitively and with some consistency, with a willingness and an openness to the experience, is that we see a habituation over time. Additionally, there's been some nice psychotherapy advancements to help with the thoughts part of OCD, especially acceptance and commitment therapy comes as similar to cognitive behavior therapy, a nice focus on thoughts and recognizing what thoughts mean, what they can and can't do, and how we can respond to those. In particular, this is helpful for people who experience a lot of the compulsive rumination that we were speaking about earlier, where it's not the behavioral compulsions, it's more the mental compulsions. Those can be trickier to try to prevent a response. It's one thing to say, I'm not going to wash my hands until it's dinner time after touching this sink. It's another thing to say, I'm not going to think about this thing that I want to compulsively think about. We don't always have the power to just stop thoughts like that. So acceptance and commitment therapy has some similarities to mindfulness and meditation-based approaches and gives people some real skill in being aware of and better able to manage how they're responding to thoughts and how much of that is compulsive and preoccupied. Typically, I'll tell people that they're going to get their best response if they combine some good therapeutic work in this behavior therapy, like exposure and response prevention, CBT, and acceptance and commitment therapy, combined with some medication intervention. The medication typically comes in the category of the antidepressant, anti-anxiety medication. There's a lot of different medications there, and they tend to help reduce general anxiety levels, but also can sometimes even start to lower the obsession part of that. There are some specific medications that have been designated as anti-obsessional, meaning that they have been shown to specifically reduce someone's obsessional experiences from taking those medications. A key thing here for people who are encountering this on their own or for the first time is that where possible, if you're not seeing the results from the usual medication interventions, it could be helpful to try to find a medication provider that has some knowledge of OCD. Sometimes it's a matter of a different type of medication that really targets OCD better. For example, there are some OCD medications that were used for depression, but they have better medications for depression now that have lighter side effects. But this older medication does pretty well with OCD and is often used. There are also, sometimes it's a dosage matter where they need to have a higher dosage than you would normally see for anxiety or depression to get some of the OCD response. I'm a psychotherapist or do the behavior therapy part. And so sometimes my role is helping people be educated about what medication can or can't do and getting them placed with a medication provider that can help them sort that out. If you are trying to figure out how to start that process, sometimes you just start with a primary care provider. They can be a good help to get you directed to a good medication provider, a psychiatrist. And if you have a psychiatrist that has some knowledge about OCD, that can be very helpful.
Lots of questions about diagnosing these disorders, and I think that's where we want to turn next here. So let me just sort of dive in, and we can bounce around a little bit on the topic, but zero in on diagnostics as we go. Can an individual meet criteria for both an anxiety disorder and OCD, or does one cancel out the other?
No, you can absolutely meet criteria for both. What we're looking at for someone is how those two interact, and if there's one that is like the predominant part of the experience. So it's very common for someone who experiences OCD to also have panic symptoms because the fears can be really intense. Sometimes we will just acknowledge the experience of panic symptoms, which would be like physiological arousal, trouble breathing, dizziness, lightheadedness, racing heart, sweating, that kind of stuff that you would associate with panic, comes up when someone is obsessively feared about something, or perhaps they've been exposed to a trigger out of the blue and they just are really panicking about that. In some cases, we'll just reference that as part of the experience of OCD. Sometimes the experience with panic has almost like a separate part to it in that they also just may have the bad luck of having a really reactive fight or flight system that brings on panic attacks. One of the differential things that we will use for that is, do they experience panic attacks out of the blue? So if the panic's occurring in the context of OCD fears, then we'll usually just diagnose OCD and note the symptoms of panic. But if they're also just having panic attacks that just show up out of the blue, unexpected, with no obvious trigger, that's a characterizing feature of panic, and sometimes deserves a separate diagnosis for that. Same with generalized anxiety or social anxiety. Sometimes those experiences are prominent enough that they deserve a separate diagnosis in addition to the OCD. Sometimes they can be best explained by the OCD.
I had a question come in about assessment tools and measures to aid in differentiating diagnosis of anxiety and OCD. What can you tell us about those?
So, in most cases, when you're meeting with a therapist, they will do a pretty thorough clinical interview. And by that, I mean, they're asking you questions about diagnostic experiences that are related to what would be for OCD, and just really getting into the detail for that. And that is often all that's necessary for a diagnosis. Some therapists will be especially attentive and use an established checklist or questionnaire. And this is just like any kind of questionnaire you might report on. So if you're at the doctor and you said, I've been really tired, the doctor may give you a sleep questionnaire, and you'll answer 10 questions that talk about your sleep and how fatigued you are. It's the same thing for OCD. It'll have a series of questions that ask and determine if there are obsessions present and what kind of obsessions they are, as well as a series of questions to determine if there are compulsions present and how serious they are. There's a really commonly used one called the Yale-Brown Obsessive Compulsive Scale, sometimes referred to in short as the Y-box. And it does a really thorough job of establishing both the presence of obsessions and compulsions, as well as how much distress or disruption those things are causing. That can be determined, including by like how many hours this kind of stuff is taking. So that's one of the things we'll be able to use to say, okay, how many hours are you spending washing your hands each day, or organizing things or avoiding things? And those become like numbers we can use to establish that. From those scales, you can compute a score, and they typically have a range that says if your score is in with this range, it's more mild OCD, moderate OCD, or severe OCD. That can sometimes be useful, but it's sometimes also so personalized that we just really need to combine that checklist with just a good interview with a clinician to help understand how this person is experiencing this.
You touched on genetics earlier, and a viewer would like you to expound on that just a bit here. How do genes factor into somebody being vulnerable to experiencing OCD? Is there a genetic link?
Yes, in that it's pretty clear that there are, in many cases, when OCD occurs for someone, it is as the result of what we might call a biological predisposition, meaning that something in the way that their brain functions makes them vulnerable to obsessions and the discomfort that causes, and seeking comfort from those compulsions. As such, that biological structure that they have in their brain sometimes is genetically inherited. And so as part of those clinical interviews, we'll also be asking questions about, do you have any OCD in family members? Are there any siblings? Are there any parents, especially direct relatives, because that can help us understand that there may be a genetic underpinning to that. To be clear, that's not always the case. So someone can show up with OCD symptoms without any family history or obvious genetic link to that. Sometimes it just shows up in terms of like the complicated and randomness of how genetics are passed down, or just how the brain forms. Sometimes we also see it as a result of just traumatic or other experiences that someone has growing up that establishes a pattern of OCD.
Very specific question that came in. How can one differentiate between OCD intrusive thoughts and psychosis intrusive thoughts?
Well, let's start first with the word intrusive. This is typically used to help establish that the thoughts are unwanted or intruding on a person's experience. But more importantly, that the thoughts don't represent how they would prefer to think, how they choose to think, or how they see themselves. Because oftentimes these intrusive thoughts can be experienced as really disturbing. They can sometimes be violent or sexual in nature, or they can relate to the possibility of causing harm to someone else. And people with OCD will often worry, does that mean that I'm a bad person, that I would want these things, that I may choose to do this kind of stuff? And it's key to recognize the role of the intrusive nature of that. I'll get to the distinction between that and psychosis in a moment, but I want to just establish a little bit more there about intrusive thoughts. There's some interesting studies that show that people without OCD, from just a regular population of people, experience all sorts of weird and intrusive and disturbing thoughts as well. It's pretty common to have some disturbing thoughts at some point in life, but they're often experienced in passing as a little glimpse, or that was weird kind of thing. One of the things that makes them feel especially sticky or defining for people with OCD is that they stick around, they become repetitive, they become obsessed about or focused on. I sometimes will compare it to like when you're listening to an old vinyl record, and if the record's got a skip on it, a part of the song that would just fly right by, and then you move on to the rest of the song. Once that skip hits, you just hear that same part of the song over and over and over, and it distorts the way you experience the song, and it creates a heightened and unnatural focus on that part. And that's one of the things about OCD, is just to imagine this idea that it gains its power through that obsessive repetition. So it's not unusual to have a weird or an intrusive or disturbing thought, but then that OCD can make that feel much more intense because of that. One of the diagnostic ideas about OCD is to recognize that these thoughts are experienced as ego dystonic, which is the fancy way of saying, this is not who I am, this is not what I want, this is not the way I would want to live my life. It's just this terrible bad luck that for some reason I've become obsessed about this. Typically in psychosis, there's a larger, much more disruptive process to the way someone experiences their own psychological experience and how they experience thoughts, to where they lose a sense of what's real and what's not. And there's a bit of disorganization to all of that. And it's hard for them to make sense where these thoughts are coming from, or that they are something that is separate and intrusive to their experience.
Another very specific question for you here, Jesse. What is so-called suicidal OCD, and how do you distinguish that from someone with suicidal ideation?
Okay. So think about our principle of OCD, which is someone becomes preoccupied or obsessed with a particular fear and then feels compelled to do things to prevent that. Suicide's a scary thing. And sometimes people can develop a fear of suicide, or that they might be suicidal, or that they might commit suicide. One of the more common ones I'll see in my practice is that people may have an experience with suicide in the family or close to them, and it's a scary thing to experience, and they become fearful that they may develop suicidal ideation, or that the same thing may happen to them. And so that they become preoccupied with that and worry that that may be the case, and then will sometimes do some compulsive things to avoid that concern. A lot of rumination with folks like that, especially a lot of checking their thoughts to make sure that there's not suicidal ideation, oftentimes checking with clinicians or loved ones to make sure that they're going to be okay. So that's that word function we spoke about earlier, to just recognize that this is just a topic that they become fearful about. And in these cases, it is very rare that they are actually experiencing what we would call real suicidal ideation, or even considering that. In the same way that if someone has an intrusive thought that they might harm someone with their car or harm someone with what they say, I don't have a concern as a clinician, nor should there be, that they're going to go out and do those things that represents this thing that they're going to do. It's just something they become afraid that it might happen. In fact, because their fear is so great, it makes them most unlikely that they would move in that direction, which makes it very distinct from someone who is experiencing suffering to such an extent, usually in the context of depression, that they're having generalized thoughts or more specific thoughts about suicide, which we refer to as suicidal ideation. And in those cases, we're cautious to take those seriously. We assess for how risky that may be. We assess for whether or not they need further support or care to help them maintain their safety and develop a plan for that.
Viewer would like you to speak a little bit to tic disorders and OCD.
Okay. So a tic is another related experience to OCD, in particular because someone can have an urge, or sometimes they might say an impulse or a compulsion to tic. And a tic is usually a behavioral or a vocal manifestation that sometimes feel random. It can be like a twitching of a body part or a vocal sound or a word or something like that. For some people that experience tics, it's a very automatic process and they just kind of come out of the blue. But for others that experience it, they will report that before the tic occurs, they will have this urge or this feeling or compulsion to do the tic. And doing the tic produces a sense of relief. So let's say, for some example, someone has a tic that they flex their neck muscles and turn their head to the side. They can get that compulsion feeling to do that. And if they do that, that'll provide that relief from that. And so that's where it has that similarity to OCD, in that you have an urge to do something, and then you feel compelled to do something to neutralize that feeling. I don't think it's exactly the same as OCD, because the tics have sometimes some different function to them, and there's also that sense of relief that comes from the compulsion, which can sometimes even be from experiences like this kind of positive, rewarding experience or euphoria kind of thing. But when we're working with that, sometimes what we will do is frame it in the same way. When you have this urge, how do we deal with that urge, and can we prevent the tic from happening, and see if we can habituate to the point where that urge doesn't create that sense that you have to do the tic, at least to give people the choice, so that if they're in a situation where they don't want to do that tic, they have some control or choice over that.
Let me ask you a big picture question here, Jesse. What you're describing is a very complex landscape in terms of possible diagnoses. Generally speaking, do you find that people are misdiagnosed often in the anxiety disorders world?
Yes, especially with OCD. I think we're getting better at this, but it's not uncommon at all for people to, first of all, not know what this is that they're experiencing. Why would they know what's going on or what's happening to them, and why these concerns have shown up? For some, it's showed up early in childhood, and it's what they've always known. But as they report it to, say, parents or doctors, and if they are unfamiliar with OCD, they can just refer to it as just anxiety or stressed, or someone just being too sensitive about something. And sometimes even with therapists who are unfamiliar with OCD, it can be processed as someone who's just overly focused on something, or needs to work through some issues with some family members or something like that. And so people can go to therapy sometimes for years, meet with different providers, and not have this stuff recognized. It isn't always clear, though, that they are OCD symptoms, because sometimes what they're doing just feels like natural problem solving. I'm just solving this problem and making this stuff better by going through all this stuff that I go through. So a big part of the OCD treatment world, thanks to especially a group like the International OCD Foundation, is to create a lot of education and awareness, so that clinicians are more aware of what's going on and can catch these symptoms and refer people for the appropriate treatment.
Natural segue from that answer to this next question. Are all therapists trained to deal with severe OCD, or would you have to find someone who specializes in OCD? We might kind of extrapolate from that question. How do I go about finding a qualified therapist?
Sure. So, no, not all therapists are trained to deal with OCD, especially if it's more severe. Also, I don't know that it's reasonable to have that expectation, in the same way that we don't expect every doctor to be fully trained to deal with every medical condition. If you had a skin issue, you would try to find a dermatologist. If you had a broken bone, you'd be talking to an orthopedic doctor. And it's the same thing with mental health. It can be a little bit trickier because that landscape is a lot more confusing, and the system isn't set up to make that easy for people to find that. That's another role that advocacy groups play in trying to help people find a good provider. So I typically tell people to utilize the database provided by the International OCD Foundation. They have a database where you can search based on your location, people who meet their standards of being trained and understanding of how to best treat OCD close to your area. There are also some increasing virtual options for that. So there's not someone who's geographically close enough to you. There are some virtual options that you can access from anywhere in the United States, many of which offer also some insurance benefits there, and just are really doing a good job of getting access to that treatment. It is worth the work to find someone who knows how to treat it on the therapy side as well as the medication side. And if you're having trouble with that, checking in with an organization like the International OCD Foundation to help you find a clinician can be a good idea. If you're a loved one of someone who has OCD and you're wanting to know, how can I help them? This is one of the areas where you can actually do a lot, is help them track down people that can know what they're doing.
We tend to have a lot of educators in our webinar series audience, and I want you to speak to them specifically for a moment here, if you would. If an educator spots a student in his or her classroom that appears to be dealing with one of these issues, what do you recommend?
I think that's a situation to handle with some sensitivity. Probably have a conversation with the school psychologist or counselor and develop a plan about how you want to approach it, in terms of, whether or not you talk to the student, whether you talk to the parents first, whether you try to do that together. And then also, one of the things that you could potentially take on, perhaps the school counselor, is to try to help refer to some good resources for that. Sometimes in school settings, they have, as part of the resources, a person who's there to do psychological assessments. The big purpose in school settings is to help identify learning disabilities so that they're getting a proper and appropriate education. Those clinicians are also often can pick up some of those symptoms of part of those assessments as well. So they can also be a good resource to point out and say, hey, where would I go if I'm seeing some anxiety or OCD symptoms for a student? Where would you recommend we send them?
Let's tackle a few more viewer questions here. Can you speak to the overlap between OCD and eating disorders? That's an important question.
Sure. We think of them as quite distinct in that they do need some specific and attentive care for each. Certainly, someone can be obsessively focused about food or fearful about weight gain, or weight loss, and do some what would look like compulsive things to do so. From what we understand about OCD versus eating disorders, is there's a different mechanism of action there in terms of what's going on biologically. The other thing that's really key is that food is a really basic part of human experience and affects multiple body systems. And so that's another factor there that's different and deserves some special attention. I think also to be watchful for is that with eating disorders, especially if there is lower weights or lower caloric intake, it can really start to impact someone's cognitive functioning and their ability to engage with treatment. And so that's a thing that needs some specific attention. There have been certainly times where people become fearful about food in a way that has similarities to an eating disorder. So remember our theme about an obsessive fear about something followed by compulsive action. So someone might become obsessively focused on eating a well-balanced diet and then compulsively review nutrition ingredients and so forth. Sometimes that has an OCD flare in combination with an eating disorder flare. And in treatment situations, we will often look to treat the eating disorder and stabilize the eating disorder first, and then manage the OCD consequent to that.
Another viewer would like you to talk about OCD and individuals with special needs such as autism. What should we know?
Okay. It is common for OCD to show up for individuals with autism or autism spectrum. So I would say one of the themes that I see a lot is that individuals with autism spectrum issues, one of the common presentations of that is to think about things in a very rigid, black and white way. And that can sometimes lead to some preoccupation or obsession with things being in a certain way, in a very rigid way, or some compulsive response to that. And so that's one of the thoughts about why those why those things can co-occur. In terms of doing treatment, there's good indication that they can respond just as well to exposure and response prevention, which is the behavioral treatment for OCD. I've noticed as a clinician that you have to be thoughtful about who the person is, how high functioning they are, and especially how psychologically minded they are in terms of being able to think about their thoughts if you use the more cognitive strategies or the mindfulness strategies for OCD, because sometimes those can be hard to utilize for someone who thinks in a very rigid black and white way. So sometimes you just have to work with them to help them understand the nature of exposure therapy, behavior therapy, and help build a connection there and help them do that therapy in a way that they feel motivated to do it, feel some sense of satisfaction to do that, and it becomes more concrete for them to do it in a behavior therapy format.
How about this one? Can OCD be completely cured, or is it something that someone learns to live with?
I think it's both. It depends also what you think cured means. I think it's important to recognize that memories are always there. So if you have an OCD episode, the memory of that episode and the awareness that it has a possibility of coming back will always be there. But I've certainly seen cases where people have an OCD episode and then can go back to more of their regular functioning. But there are some for whom it can be there in their life and requires constant management. And management can vary. Sometimes it takes a lot of work on their part. Sometimes it just takes some just regular attention to make sure that they're staying on top of things. In all of these cases, though, I think there's a good chance for a decent outcome where if they do some work on the treatment side, both for medication and behavior therapy, that it get to a point where they get a significant amount of relief and be able to do the things that they want to be doing with their life.
I want to touch briefly on the role that the pandemic has played in this whole conversation. Have you found there to be a lingering impact from the shutdowns, for example, in terms of people's dealing with anxiety in various forms?
Yes. I think I saw it show up in a few ways. One of which was a lot of people that I work with OCD were ready because this is what they experience on a daily basis throughout their whole life. For some, they would tell me that like it was somewhat validating to see that other people were finally experiencing what they go through in terms of like obsessive fear of germs and contamination and having to do some extreme things to prevent all of that. And so they signed right up, did what they needed to do to be able to manage that. For some, though, isolation and lack of activity can be really tough for anyone. With OCD, it can be really, really tough because the less active you are, the more isolated you are. It can sometimes give OCD a stronger hold on you or more of an opening to cause issues. And so that's where I've seen that pandemic experience worsen the OCD experience for someone, is that it just the isolation and the lack of activity gave them more time to be obsessed about things, more room for rituals to be performed, etc. One of the key ingredients for more holistic treatment, in addition to the therapy and the medication, is to keep people busy, to be involved in work or school or volunteer and exercise and social activities so that the OCD doesn't have as much space. I'll often compare it to like your life being like a large empty warehouse. And if it's just you and the OCD in that big empty space, that's the OCD is going to take up a lot of your focus. But if it's you in a very rich list of activities and experiences, that makes a difference. The final thing I'm noticing is that, the pandemic was a major stressor, and stressors take some time to heal and recover from. And there can sometimes be some just burnout and exhaustion on the other side of that when it seems like things are largely returning to normal in many cases. But there's just some psychological burnout and fatigue from that. And so I'm also seeing people who are, holding on tight, trying to manage OCD in their lives, but it's, they're tired, they're burned out. It's been a rough few years. And so it's been harder to stay on top of that the way that they were before that.
As we start to wrap things up here, I wanted to give you an opportunity to pass along some favorite resources. I know you mentioned the IOCDF website, for example. Are there other websites, books, videos, whatnot that you would point our viewers to for more information on this topic?
Yeah. Um, I think the International OCD Foundation or their website, iocdf.org, is just a great place. It's a really well-run organization and a lot of dedicated people to try to get the word out about this. They recognize the need for people to be more informed about this. So the website is full of lots of educational materials. You could spend some time on there just kind of going through some quick web pages and really feel quite educated about what's going on. So that's usually where I send people first. If you'd like some more detail, the book I often recommend is a book by Lee Baer called Getting Control. And it just has a nice section that describes OCD and its various presentations and what we understand about it, as well as how to treat it both on the therapy side as well as the medication side. So it's just a nice general introduction to that. And those two resources are probably the best places to start.
Jesse, we have covered a lot of ground over the past 60 minutes. Thank you so much for your time and loaning us your expertise today. We very much appreciate both.
Happy to do it.
Dr. Jesse Crosby. To those of you watching today, thank you for your interest in our educational webinar series. We hope you'll come back for our future sessions, and we wish you a wonderful day.